Hello, hello, and welcome to the Feeding Pod. This is your host. I'm Brianna Millick, and I am a speech language pathologist and certified lactation counselor. I specialize in infant and medically complex feeding and primarily see patients in the home health setting, although I do have some that I see in outpatient or via telepractice. I'm also an instructor at the university level and a PhD student studying communication and information sciences. I have a huge passion for evidence-based practice and supporting information literacy in speech, language, hearing, feeding, swallowing sciences, specifically as it pertains to social media and translational research. This podcast is meant to share anything and everything related to being a pediatric feeding SLP, feeding therapist, with sprinkling in a little bit about working in academia, being a PhD student, and how to access, appraise, and implement research into clinical practice. Some episodes may contain guests, and I'm already looking forward to some of those coming up, while others might just be me rambling about something that's been on my mind. Regardless, my goal with this podcast is that you walk away not just with newfound knowledge, but with the inspiration to think critically and not be afraid of research. So without further ado, let's get into today's episode. Welcome to episode 2 of the Feeding Pod. In today's episode, we're going to discuss what is a pediatric feeding disorder.
All right, so what are PFDs? A pediatric feeding disorder is an impaired oral intake that is not age appropriate and is associated with medical, nutritional, feeding skill, and or psychosocial dysfunction. Estimate that PFDs affect more than 2.3 million children under the age of 5 in the United States. Just for reference, that is more than are diagnosed with autism each year. For these infants and children, every bite of food can be painful, scary, or impossible, potentially impeding nutrition, development, growth, and overall well-being of the child. Up to 1 in 23 kids will be diagnosed with a pediatric feeding disorder.
Under the age of 5.
Good news is it's going to be added to the ICD-10 code starting in October of 2021. So that's really exciting. That's big for us.
Yeah, that's super exciting. And a huge shout out to Feeding Matters goes for all the lobbying that they did to really push for PFD to be an official diagnosis. And this is going to be so important for so many of our children and families. Feeding Matters, if you don't know, is just this absolutely amazing organization that I'm super passionate about. They're really the first organization in the world to unite families, healthcare providers, and just the community in helping provide care for children with pediatric feeding disorders. And they do this through advocacy, like I said, like lobbying at national levels, educating, supporting, and providing research. And if you haven't already, go to their website, feedingmatters.org, and check them out. They are amazing. And they provide something that was really missing in the pediatric feeding world for a very long time. So we'll just kind of dive right into it. We're going to go more in depth into the different aspects of pediatric feeding disorder and some resources and support. Feeding Matters really created this coordinated care model that looks at the complexities of pediatric feeding disorders. So overall, focuses on 4 key domains. These domains are, if one or more than one are impacted, this is gonna affect a child's well-being, their quality of life, and not just theirs, but the whole family unit. This is medical, nutrition, feeding skill, and psychosocial. So I start by going into the medical side. So eating and swallowing is super complex. It involves the entire body and its organs working as one unit. So if one of these parts is out of sync, the whole unit is going to have trouble. So it takes 13 paired muscles, 26 total, and 6 cranial nerves to work in perfect harmony to move this food and liquid through the body. So from the moment that you are even thinking about eating or drinking, your whole body unit is working. And so it takes such a small amount of time. We think of swallowing as being just seconds, but this is something very complex and can be very physically demanding for a lot of the infants and children that we work with. And especially you think just after birth, the first few weeks of life, this is something that can already be impacted. And so the medical side involves all those different systems, and also reiterates why it is so important for us to work in like a multidisciplinary fashion.
It takes all of us to help these kids out. It doesn't just take one person. It takes more than it. It's an entire team approach. From the nutrition side of things, if we're looking at growth and development, these kids can come to us and only eat one or two foods and be missing big components. We sit here and we think about, oh, it's super easy to chew up this piece of chicken and it's easy for us to get in our protein, but these other kids may not be able to chew the piece of chicken, or they might not be able to chew and swallow anything at all by mouth. Some of these kids may come to us on feeding tubes, and that's their sole source of nutrition because they haven't been able to develop the chewing and the swallowing. 100%, our overall goal is to get these kids off of feeding tubes and get them chewing, swallowing, being able to meet nutrition needs orally versus through this feeding tube. If you don't use it, you lose your muscles. That's a big saying with speech therapists. So we've got to use the muscles. We've got to learn how to use them. We've got to get them going. And a lot of these PFD kids that come to us with feeding tubes, it takes a long time. The nutrition standpoint from it, okay, we've transitioned to solids, but now we're only eating 3 foods. Are these 3 foods able to meet our protein needs? Are they able to meet our carbohydrate needs for the day? Can we get in enough fat? Okay, so we've got our 3 main food groups. We're getting in those, but what about our vitamins? What about our minerals? Are we getting in enough vitamin A? Are we getting in enough vitamin C? What about vitamin D? So that's where we really come in and we fine tune and we make sure that we're getting in all of our calories for the day, that we're getting in all of our protein, fat, vitamins, minerals, everything that we need to support healthy brain activity, fine and gross motor skill development, and just overall health and wellness.
I think the nutrition side also provides that benefit for a child to understand what it is that their body needs as well, and their hunger and feeding cues, and understanding that, because a lot of these kids that come to us that have been on a feeding tube, especially for a long time, they have no idea what their hunger cues are, what they look like, when they're full.
Mm-hmm. And especially from, if we go into the caregiver side of things, a lot of these caregivers, if they're giving 2 feedings, if they're even giving formula through a bottle, they're so focused on, okay, my kid is getting this amount at this set of time, and this is how many calories they're getting. They're getting this much protein. They're getting this much fat. These caregivers really know what their kids are getting, into all of a sudden, hey, by the way, we're going to take this away, and you're going to feed them by mouth, and you're not going to have any idea exactly how much they're getting. And that can be a big issue because they are so used to being in control of, my kid's getting this many calories in a day. And now all of a sudden we're throwing a totally new curveball at them. And that's where I think us as dietitians really come in to say, hey, listen, we're going to work with your kid. We're going to help them identify their cues. But also, even Bree from the speech therapy and feeding therapy side of things, they work on the feeding cues as well and work with the kid of, okay, we're hungry, we're going to eat this. This is what hunger should feel like. This is what we're looking for. And working with the caregivers on being able to recognize hunger and satiety. Sometimes these cues are not going to be the typical cues that you see in a normal developing child. Even if I try to compare the difference between my 16-month-old and Daniel a lot of times will not tell you that he's hungry. He's not going to show any signs that he's hungry. The kid would probably sit in his room for, I don't know, the entire morning without coming downstairs to get breakfast, without that reminder cue of, hey, it's time to eat breakfast. Let's come on down. We're going to eat breakfast. Meanwhile, Harvey's going to be over at the pantry door screaming for you to open it because he's hungry. Just 2 completely different ways of trying to navigate. Daniel also cannot tell you when he's full. He is that kid that whatever you put on his plate, A, he's going to eat. B, if you ever offer seconds, he's going to continue to eat seconds until you stop offering. So with Daniel, it's been a lot of, we're just watching him, and it's watching small things like, okay, he's slowing down. Mm-hmm. All right, that's a cue of, we're done. We need to stop the meal. We need to end the meal. He's going to be the kid that will overstuff. He'll keep eating until he's sick. Mm-hmm. So it's definitely fine-tuning what these cues look like, because they're going to be different for every kid.
Yeah, for sure. And I think that ties into that domain that's psychosocial. We provide certain aspects, but that's why this outline of pediatric feeding disorders is so important and so essential, because these things overlap. And even you talking about the parents who for years, sometimes that they have fed on this very specific schedule. They know exactly how much their child's getting because they're the ones giving it to them every so many hours and X amount. And the trauma of that for families is real. That can be so hard to let go of. And so working with therapists and counselors on that side of it is just as important, because anything that the child is experiencing, the family unit is experiencing. And that relationship between the caregiver and the child is so important, especially when we're thinking about feeding. Mealtimes should be happy. They should not be stressful. And for a lot of these families, they really are.
It can be very stressful and overwhelming at times. Just even coming from Daniel, we can tell sometimes it's just getting him to the table can even be a struggle for us. It can be a lot of crying. It can be a lot of breakdowns. It can be a lot of, he just doesn't want to be present at that meal with everyone. It can be overstimulating from the autism side of things. It can also be overwhelming from the side of you as the caregiver. You've been given instructions by your feeding therapist to, hey, let's set a timer and we're going to chew for this long. And then this fun little thing's going to play at the end of the timer to say, hey, congratulations, you chewed for 15 seconds. Things like that can be overwhelming to the child doing them 24/7. And it's a lot of multidisciplinary things that come into play. Trying to find that fine line of, hey, do I actually make my child continue doing these skills at home, or do I just let it go, let mealtime be fun? There's a lot of just things that you have to navigate as parents that a lot of times the therapists don't see or don't understand where you're coming from. And I think we as a unit all need to make sure that we're constantly relaying information saying, hey, we're struggling with this, or hey, we're struggling with that. And maybe we're just not going to work on our chewing skills at dinner time because now we're having issues at meal times.
Definitely. And I think that's where we both take this approach of us just making it functional for each family. Whatever you are targeting, you have to think functional, and how does that carry over for the family and the caregivers. Going into that last domain of feeding skill, this is the child being able to learn to eat safely, effectively, and comfortably. So it's the sensory side, the oral motor side, talking about those cues and prompts. But really, if a child is hungry, but they cannot, from the oral motor level, at the level of their mouth, be able to chew their food without, just like with Daniel, risk of choking, and you're having to cut it up super tiny. Okay, how can we make this more functional? How can we make this child more independent? Because our goal is self-feeding and that they are happy and enjoy those meal times. And of course, there's going to be meals that your child eats more than other meals, and there's going to be fluctuations with that. But to know that when they come to the table and you prepare their food, that they can safely bite, swallow, chew, that's the goal, and functionally. So if doing some of these strategies aren't, and I think that's something I would tell families as well, and I always try to check in with my families, like, does that make sense? Is that something you can achieve? And if it's not, we're going to figure out something else, because if it's not functional for the family unit, it's not going to get carried over. And we've talked about this a lot with like behavioral type strategies. If you don't figure out what is actually going on with the child, these behavioral strategies aren't going to stick, because you're just going to keep pushing for the same thing, and the child's going to do it just so that they can get their reward. But in the end, it's not going to carry over. And so working on that standpoint of stuff. And I think what we've showed even in this conversation is how, yes, there's 4 domains, but all of these overlap. The medical, the nutrition, the feeding skill, and the psychosocial, those all come together and are what really make up a PFD.
And to be honest, all of this comes together in any type of situation with any special needs child. It's all a multidisciplinary approach, and all of it just melts together in one pot. And it's just, you keep stirring and you keep getting this input from this one and that input from the other one, and they all work together, and hopefully the overall goal will eventually be achieved. And I know sometimes that can be hard for families. I know with Daniel, even when we do the smaller pieces and we cut food up for him, Okay, what is his default then going to be? I'm going to shove as much food as I can in my mouth because now I can fit more in my mouth because it's cut smaller. So it's finding that fine line of, okay, do I make them into bigger pieces so that we work on the skill of chewing? Or are we just going to take that big piece of Chick-fil-A chicken nugget, shove it in our mouth and swallow it whole? That's his new thing. And he'll try to hide it from you. You can even ask his feeding therapist. He will turn his head and hide it from her now and throw it in his mouth and swallow it. And then come up, his eyes are going to be watering. You can tell it is killing him going down, but nope, that's what we're going to do. Daniel is a fun one. Let me just tell you that one.
Yeah. All right. So taking a deeper dive into the different domains and the factors associated, I'm going to start with the medical factors. So this really involves impaired anatomical and or physiological function of the GI, cardiorespiratory, and neurological systems. These are often associated with dysphagia. And I do want to clarify, when I refer to dysphagia, I'm talking about oral, pharyngeal, and or esophageal. So all levels of it. First of all, starting upper GI tract dysfunction. This can be from a GI anomaly or a disease. It could be secondary to a respiratory or airway pathology. The oral, pharyngeal, and laryngeal anomalies they just impact normal feeding. And this can vary. So this can be reflux. This can be EOE, which is eosinophilic esophagitis. It can be motility issues, slow gastric emptying. So can only eat small volumes because if they eat too much, they're going to vomit because there hasn't emptied yet into their digestive tract. You might see feeding volume intolerance. You might see gastroparesis, any of those things in that upper GI tract. Additionally, there's other components, usually typically referred to as like the aerodigestive diseases. So these are diseases of the airway and lungs, which result in pediatric feeding disorders. One example of this is chronic tachypnea, which impacts the suck, swallow, breathe coordination. So this can impact breast and bottle feeding. Chronic lung diseases, this is often found in prematurity. And as many of us know, because of medical advances, we're seeing more and more children born premature or medically complex survive, which is amazing. But then we have these side effects that we have to go through and treat. And so that's one example that impacts the ability to swallow and feed. An aspiration that results from a feeding disorder can manifest as a lower respiratory infection, turn into pneumonia. So with these children who are already at risk of breathing difficulties, if you add that pediatric feeding disorder side to it and this child aspirates, then we got a whole nother slew of problems going on. Looking into more of the cardiac side, congenital heart disease is something that often can delay acquisition of feeding skills because these children typically have to have a lot of critical care interventions, hospitalizations, surgeries. And these surgeries actually can result in damage to the recurrent laryngeal nerve, which can cause vocal fold paralysis and impair airway protection. So then not only are they having some cardiac stuff going on that impacts feeding and swallowing, but they also have the neurological side from the nerve damage. Chronic hypoxia is also something that can play a role in this. Loss of oxygen at birth or after birth can impact a child's ability to feed. Children with neurological impairments are at an increased risk of pediatric feeding disorders, and children with more severe motor and cognitive delays also, which makes sense. The more medically complex a child is, the more likely they are to have feeding or swallowing disorders. And research has shown children with developmental delays or other underlying diagnoses are at a significantly increased risk of having a feeding disorder. So, all of those different aspects really play a role into the medical side. And when we think about using that multidisciplinary approach again, as we talk about over and over again, and we will continue to talk about, some of the specialists that you might interact with include a developmental pediatrician. And I know, Olivia, like you can probably talk about some of these specialists along the way, but developmental pediatrician, pediatric surgeon, allergists, cardiologists, dentists, endocrinologists, GIs, geneticists, neurologists, nurse practitioners, ENTs, pulmonologists, radiologists. I could go on and on.
Just go ahead and name everyone.
Yes. Yeah. Sometimes it's sad, but sometimes us as the dietitian or SLP can be the first person to tell these families that one of those other specialists might be able to help in the progress of treating the child's pediatric feeding disorder.
Yeah, actually, the patient that I saw the other day, between myself and the feeding therapist, we came up with a list of, hey, you actually need to go see GI and you actually need to go see an allergist because there's something going on there that they could probably help you out with a little bit better than what we can.
Yeah. And we really have to, as professionals, consider this side so much more, because if we don't figure out what underlying medical thing is going on, we will not be successful in any form of treatment.
We can't diagnose anything medically in our profession. So you need to get the diagnosis so we can help you in the correct way.
Yeah, exactly. And I really like to use the term response rather than behavior. The child is not showing negative behaviors. They're showing responses to something. Behavior is really a form of communication. And so with a lot of these, and I'll just flat out say, I don't use behavioral feeding strategies. I really try to use more responsive feeding strategies. But even with responsive therapy, if we don't respond to those behaviors and what the child is showing us, which is typically some underlying medical diagnosis, we're not going to get anywhere with responding to their cues, because you're going to reach a point where these kids are not going to just eat because they're hungry. And so it's really our job to look at red flags, look at those cues that tell us, hey, I think that we need a referral to GI, or we need a swallow study, or we need to see ENT, or whatever it may be.
Definitely. And jump into some nutrition inside of the PFDs. So a lot of these kids, we don't think of it this way. And I was actually telling Bree, malnutrition to me is common sense. They're gonna be suffering from malnutrition to some sort of an extent. So what is malnutrition? Malnutrition is defined as an intake of nutrients insufficient to meet nutritional requirements. So as I was saying earlier, are they meeting their energy needs? Are they meeting their protein needs? Are they meeting their carbohydrate needs? What about their micronutrients? This affects the development and growth of your child. You may not think of it that way, but if your child's not getting enough fat, then their growth can be hindered. Same thing for protein. Same thing for just getting in enough calories. A lot of these kids come to us with failure to thrive or some form of malnutrition. We also don't put 2 and 2 together with some vitamins and minerals. Some vitamins and minerals can cause neurological issues. Therefore, we might not develop appropriately neurologically. There's a lot of things that come into play with malnutrition and failure to thrive that a lot of times even your general pediatrician might not be putting 2 and 2 together. So that's where us as dietitians can come in and say, hey, you're not getting enough of this or you're not getting enough of that. We just don't commonly think of vitamins and minerals and getting enough protein and fat affecting the development of our kids. Yeah. A lot of these kids also just have restricted dietary intake. This kind of plays into the psychosocial type of things with this, but it could be sensory oriented. I have one kid that just anything that's green, we're just not going to eat anything that's green, period. Not going to happen. It's more of a color thing. He just doesn't like the color green. It can be a texture thing. So maybe it's a texture. They don't like pureed foods, but they like solid foods, or they don't like solid foods and only eat pureeds. I have a 6-year-old who is gonna only eat pureeds. He's gonna refuse anything solid. Is it sensory? Is it we haven't learned the skill of chewing? What is it? I can't diagnose that. That's not part of my diagnosing, but I can work with him to say, okay, so we really need to add this into all of our pureed foods to make sure we're getting what we need.
I think that's where the collaboration part comes in so strongly, because I can work on improving our skills to go from the purees up. But if this child has malnutrition, it is so hard to teach new skills when a child doesn't feel good, when they're chronically tired, when, they're just, every time you bring food around is something difficult. And so establishing that side of it, getting it's constipation that we have to take care of so that they're even just willing to accept the purees that will give them the right nutrients. So then we can effectively improve their skills.
And there's a lot that we work with pediatric feeding disorders, because some of these kids don't come to us with just one disease state. A lot of these kids have 3 and 4 and 5 and 6 and 50 million different issues going on. I hate to say it, a lot of them that we do get are autistic. So what are our GI issues related to autism? 80% of them suffer from some sort of GI issue. Constipation is a big one. So is it the constipation affecting the oral intake? Is it the act of chewing and swallowing? Is it texture aversion? What is it? We're identifying a lot of different things, and we rely on each other a lot back and forth of collaborating of, hey, is it sensory oriented more on your end, or is it just not having the proper muscle tone to chew and swallow the foods properly? They're definitely, as a feeding therapist, diving more into that, relaying it to me so that then I can alter their diet to meet where they're at that point with their feeding disorder.
Yeah, and I think a lot of times it's this cycle. So a child has some underlying medical diagnosis that has not been found. And so their response to not feeling well or something being difficult is to not eat it. And so by not progressing our diet or not eating a variety, in turn, we're not getting the experience. We're not building the microbiome.
Which I was going to go into next is a lot of these kids don't have the proper gut microbiome. So you might see some immune issues. They might always be sick. What if we always have a cough and a cold? Is it our gut microbiome? If we're only going to eat Oreo cookies, our gut microbiome is not going to be great. We might end up with the issues like constipation. We might end up with a chronic cough and cold because we just don't have a healthy gut. A healthy gut's going to help us feel better too.
Yep. Yeah. And that's where it just cycles. Like, we don't have the healthy gut. Now we don't feel good. So we don't want to eat new foods. And it's that vicious cycle, which is why each portion of this is so important. So diving into the next domain of PFD is the feeding skills. So the feeding skills really involves like oral sensory functioning, oral motor functioning, pharyngeal structures and sensation, social influences, and environmental factors. And this is important because learning to eat effectively and safely is very important. It's rooted in the development of sensory experiences that then in turn build on the motor experiences. And feeding skills really includes social side as well. So we talk about enjoying meal times, making it stress-free. So diving into the oral sensory functioning, this is the child who doesn't accept foods that are cold, or will only eat certain textures, maybe only certain flavors or sizes. They only want small pieces of food. If it's big, it's too overwhelming. This is like hyper responsive or hypo responsive. Maybe the child is nervous about foods, and so they take small bites, but then you also might have a child who has more difficulty detecting that something is in their mouth. And so they tend to overstuff and take really big bites. So there's both sides of it. And a lot of these children with sensory functioning difficulties will gag. These are the kids that will see that they gag when they look at it, if it's a different texture that they don't like, and can make it hard for them to eat. The oral motor functioning side is how a child really manipulates and controls the bolus, how they can transition, lateralize foods, liquids, being able to swallow. Are they messy eaters? Do they have a lot of spillage? Are they able to appropriately chew and form their bolus to propel it back for swallowing? And this is where we might see gagging during some of this as well, if they have a loss of control. So this one isn't so much of the sensory side of it, but maybe they just can't control the bolus well. And so it slips back. And then that's when they're gagging. With the pharyngeal structures, this really involves instrumental assessment. We can see some overt signs and symptoms of aspiration, coughing, watery eyes, redness, things like that, but we really do not know if there's something going on at the pharyngeal level without a swallow study. And this can be FEES or modified barium swallow. And then pharyngeal sensation, that's another thing we can't know for sure. But if we have decreased sensation in our pharynx, then our airway is not as protected. And this is actually something that I see in kids who have severe reflux. If they have really severe reflux, and a lot of times these are kids that don't show those typical reflux signs. They're not vomiting all the time. They don't have excessive spit up, but they refuse to swallow solid foods, or they cough a lot on their liquids and they didn't used to. And it's because the reflux is just so severe that the sensation is reduced or just off. Think of this as you psyching yourself out before you swallow because it's going to be uncomfortable. I think about if we're on an antibiotic and it's this huge horse pill. I swallow pieces of food bigger than that all the time with no problem. But for some reason, taking that whole pill and putting it in my mouth, it's a mental game, and it just literally in my mind, I'm like, this is really big. Am I going to try to swallow it? And then I end up gagging. I can't swallow it. I get frustrated. It's the same thing with these kids with reflux. They know, wow, I really do want to eat that, but it's not going to feel well. Or I'm trying to I'm trying to compensate for the sensation stuff going on in my pharynx. And so then we see those other signs that are happening. It makes the swallow not as efficient, not as safe. That last part, the pharyngeal motor functioning, this a lot of times it is seen more, I wouldn't say all the time, but I see this a lot in my neuro kids. So they have some reduced strength and coordination of the pharyngeal constrictors. Maybe their vocal folds don't close appropriately, or they have some paralysis there. Some of these signs that they might have some pharyngeal motor functioning issues is having to do multiple swallows, always congested. They're not able to clear everything. Poor airway protection, a lot of coughing. And again, though, we cannot determine for sure there's something going on at the pharyngeal level without an instrumental. There's also the social influences. So what's going on with the family, what's going on in the environment, the environmental factor. Are there strategies at home? Are they comfortable? What has been used that was helpful? What was done that wasn't very helpful? So all those different factors. The dysfunction of skills occurs when a child is not able to eat safe, age-appropriate diet and efficiently. We use the under 30-minute meal rule, allow for some socialization. And so unsafe oral feeding would present as choking, aspiration, adverse cardiorespiratory events, so apnea, bradycardia during oral feeds, or other adverse mealtime events such as gagging, vomiting, fatigue, or just complete refusal over and over. Delayed feeding skill is for a child who is unable to consume age-appropriate liquid and food textures. The child might be able to eat orally, but has to have everything blended, and they're 5 years old. Or they have to rely on a different form of the food than what is age appropriate. They might also have difficulty using feeding utensils or other devices, or have trouble with self-feeding skills. And we talk about this, that self-feeding is so important. It allows the child independence. It allows them to be able to decide if they're full or hungry, if they're ready for a bite. That preparatory stage of picking up the food and bringing it to their mouth, their body's already getting ready to accept a bite. So that's really important. And then inefficient oral feeding is that prolonged mealtime duration. So is it taking more than 30 minutes, or are they not able to get enough in? So maybe they're getting enough, but it takes over an hour to get their feed in. And I feel like this is talked about a lot with infants as well, with bottle feeding. Like, oh, they'll take 3 ounces, but it takes 45 minutes for them to get 3 ounces in. And so you're thinking they're not gaining weight because by the time they're getting in what they need, they've worked so hard to get in that feed that they've burned the calories of what it was that they got in. These children might also require modifications of textures, special equipment, specialized adaptive seating, or nutritional supplementation. And when we refer to nutritional supplementation, I want people to understand this does not necessarily mean tube feeding. It could be that your child just drinks Pediatric. So even if it's oral intake, it's still a supplement to what they should naturally just be able to have.
Okay, so I'm going to go into some psychosocial components of this. A lot of times we don't think of what we need as far as psychosocial for these kids. This can be the case of a psychologist helping out with feedings, a behavioral analyst, or a counselor who just specializes in this feeding training. We just don't think about the mental health and well-being of the kids and of the caregivers. A lot of this can go into reading cues, even for these kids that can't fully express themselves, getting the type of training that you need to better be able to feed your kid. Social workers can assist with this. Like Bree and I were talking about earlier, we both have just our own therapists even that help just with general things. As a parent and a caregiver, sometimes you just having someone to talk to about these psychosocial issues that come along with a pediatric feeding disorder can be helpful and help you better prepare these meals and better just give your child better care overall. Some other psychosocial components that we may not think about are those feeding cues, the hunger and the satiety. So learning how to read these cues, that can be part of the psychosocial treatment. So I like to refer to Ellen Sater and all of that great information that she has, because we don't want to overfeed these kids or underfeed these kids. We need to make sure that we are giving them exactly what they need. And there's different responsibilities for you as the parent and the caregiver versus the child. So a lot of times when we're transitioning from that stage of just formula feeding or just tube feeding, or hey, my kid just never developed typically, so I give them 7 Pediasures a day to make sure that they're getting in their food. And then we're switching over to regular food. How do I read that they're full? How do I read that they're hungry? How do I know? Because I've always done this at this time and given this many calories. First of all, I do suggest still giving your meals at meal times. Even being a responsive caregiver, we're supposed to respond to exactly when the child is hungry. But if we can't fully read their cues, sometimes it's helpful to give, hey, this is our breakfast time, this is our lunch time, this is our dinner time, and these are going to be our snack times. And providing the kid with their food at that special time that you've set aside of these are our meal times, but not forcing the food on them. Give them a small amount on their plate. Let them decide how much they want to eat. This can be hard, especially in our kids that can't self-feed. So what if your kid has cerebral palsy? They can't get that fork or spoon or whatever to their mouth, and you're having to do it for them. So if we're giving hand over hand and that kid is just fighting against you, that kid might not be hungry at this point in time. And it's saying, okay, that's okay. We're just going to end the meal and we're going to move on. We'll give our snack during snack time. And maybe that kid wants to eat a ton of food during snack time this day. You're still offering your meals at those certain times and you're honoring your kids' cues. Like I touched on earlier, it might not be the same cues every day. And it might not be the same cue that Susie Q gave their parent. Like I mentioned earlier with Daniel and Harvey in one of my other episodes, I believe it was in episode 1, Harvey's going to go to the pantry and scream and you know he's hungry. Daniel may not ever tell you that he's hungry. Sometimes, very rarely, he will say, I'm hungry. Okay, great. You are saying that you're hungry. Let's get you some food made. Mm-hmm. But a lot of times we're having to decipher those cues on our own for Daniel. How to know that kids are full when they can't communicate is looking at subtle cues. Honestly, I challenge you to video record your child during meals. This actually has helped me out a lot with both of my kids on learning their cues. So I picked up on Harvey. Sometimes his first cue was taking his spoon and trying to feed a dog. Okay, he's done. He's trying to feed the dogs. With Daniel, it was picking up on, hey, look, he's really slowing down on his meals. He's like really chewing that bite of food and he's putting the fork down and he's not just shoveling it in his mouth super fast. If he's shoveling it in, he's hungry. If he's not hungry, but he doesn't have that, how do I call it? That satiety. He doesn't have that satiety cue. It's either gone from parents just not working with him and being responsive with the feeding, or he just might not ever have it. I've read a few research studies that show for some reason those Down syndrome kids just sometimes lack that cue, or they ignore it and suppress the cue. We don't really know because sometimes these kids can't communicate that with us. Mm-hmm. So it's picking up on the subtle cues. So I do challenge you, go check out the Ellen Sater Institute. She has a lot of great resources for both professionals and parents as far as reading those cues and being a responsive caregiver versus you taking control of the meal and saying, hey, we're going to eat this much and we're going to get this whole thing of baby food in and it's going to be great, or we're going to get this entire plate of food in and it's going to be great. Sometimes if you look at your diet, on Monday, you might have ate the entire pantry and then on Tuesday, you might not be hungry at all. We don't have the same appetite every single day. If we did, we'd be machines essentially. Everything fluctuates with us.
I think pigging back off of too what you said about with some of the kids just providing that schedule, while it's important for the parent to decide like when the child's going to be eating, then within that you can read their cues. And I think this is especially important with our children who might not have their cues yet. You just have to establish that schedule, and it might take a couple weeks for them to consistently understand when they are hungry. But by creating that schedule, you're allowing them that flexibility, especially if you're working on weaning from supplements, whether that's tube or oral, to allow them to feel hunger and allow them to understand that. And then you providing them the language when it happens. I think the other part is transitioning into our last part of resources. And you talked about check out Alan Satter's Division of Responsibility. And if you're a parent, I highly recommend you go to Feeding Matters and check out their Power of Two program. They will hook you up with a parent or family who is going through something very similar to you that can just provide that side of support that you need. And building that psychosocial relationship, fill your cup so that you can fill your child's. Because if your cup is not full, you will not have anything to give. And it's so important to take care of yourself as well. The other thing that Feeding Matters does is they have a financial assistance program, and then they're just so wonderful about lobbying for, this diagnosis code is one example, for insurance coverage, just so many different things. I can't say enough good things about Feeding Matters. Check them out. Go to their website, feedingmatters.org. And then something else, the one last thing I want to share is that they have a questionnaire that I refer, and I know Olivia, you too, we refer families to use to help them identify, does my child have any red flags for a feeding disorder, and should I seek support? And I find this to be helpful as well for pediatricians. I actually have a couple of pediatricians that will use this in their office, and I think it's wonderful to say, hey, fill this out for me. And it will let them know, yes, I do think we need a referral and we need to seek services to be able to get your child on track with their feeding skills. Because like you said, sometimes it's subtle things. It might not be super obvious that your child is going through something, or it just might look like picky eating, or it just might look like behaviors. But like we said, behavior is a form of communication. It's a response. And so it's just really important to seek services early, look at all 4 of these domains, and consider the child and family unit as a whole as we go into providing assessments and treatments.
Yep.
So.
The quicker you identify, the quicker we get treatment, and the easier it is. The longer you put it off as a provider and as a caregiver, the harder it is to treat it.
Yep. Awesome. I hope this was helpful, and we look forward to seeing you guys at the next episode.
Thanks for tuning in to the Feeding Pod this week. If you enjoyed today's episode, please don't hesitate to share this podcast with your friends and colleagues, and leave us a 5-star review wherever you're listening from. If you're interested in learning more about pediatric feeding and swallowing, be sure to follow me, on Instagram at Pediatric Feeding SLP, or check out my website where you can get access to more courses and information, www.pediatricfeedingslp.com. Again, thanks for being here and listening to my ramblings, and I hope you'll keep listening. Until next time, cheers.